All right, everyone, let's start this next session. My name is Richard Melchior. I'm a perfusionist at Children's Hospital of Philadelphia. I'm actually getting punished right now, I believe. I've talked too much in the past 2 days, so therefore they're putting me up here to moderate this session. I'm going to take the place for Tammy, unfortunately, for this session. We have three amazing speakers for this session. The first is a gentleman by the name of Isaac Chinnapan. I've had the pleasure of knowing Isaac for many years now. He is currently the chief pediatric perfusionist at Johns Hopkins, and does a phenomenal job with several professional organizations, including AMSECT and the Academy. He has many accolades, several publications, and what he brings to the table every single time he gets to a podium is nothing but spectacular. So without further ado, I'd like to introduce Isaac Chinnapan for his talk today.
Good mid-morning, everyone. Thank you for coming back for this session. First of all, I would like to thank the Sanibel Scientific Committee, Rich, and Vicky, one of my perfusion friend from Canada. She's the one introduced to me about the Sanibel perfusion. I've been in the profession for the past 15 years here in the US, but this is my first meeting. So thank you everyone for the great meeting. Rich asked me to give a talk about ventricular assist device. So there are two options for me, either ECMO or ventricular assist device. This is not the topic of my choice because our practices most of the time, surgeons command, get ready for Impella, get ready for Berlin Hartmann, just we will go and we'll follow the commands. So, but what is the science and specifics with reference to the various ventricular assist devices? I'll give a brief idea about what we are doing in the current era of ventricular assist devices. No disclosures. Before going for the further discussions, I would like to know in this hall, how many pediatric perfusionists having a full VAD program in your centers? So only 5 or 6. So I can cover most of the things because it's a very challenging area. As I mentioned during my question session, the previous session, it's a very low frequent, highly sensitive area. So for the objectives purpose, first I'm going through the literature review 2018 to 2023, actually 2024 February, how the VAD program is going on in this country or around the world. Number 2 is the science and specifics. When we talk about the science and specifics, one is continuous flow, number 2 is the pulsatile flow. Over the years, for the past 10, 15 years, the concept of the pulsatile versus continuous flow is gradually changing. And what is the change and how we are doing the best for our patient population is the second objective. Next one is how to plan for the course of VAD management. So when we talk about the VAD management, personally as a perfusionist, two wide areas. Number one is just making the settings, transportation, implantation, and periodic rounds by the perfusionist when the patient is on VAD. That is number one. Number two, algorithmic anticoagulation management. That is a more complex topic. So I chose to go with the science and specifics. What is the flow, how to implant, how we are managing the patients, those things, and how the trend is going on in this country around the world with the VAD program in pediatrics. Device-related complications is whenever patient is on VAD, the device-related complications is one of the area we should be aware of. And finally, what are the challenges and the level of competency required for the practitioners? As I mentioned in the previous session, this is very low frequent and highly sensitive area. So how we can keep competent to take care of these challenging cases. So VAD in pediatrics, if you see in the past 15 years, it is in the revolutionary or evolutionary phase. In 2012, when we started the VAD program during my time at Vanderbilt Children's Hospital, the first patient was 4.6 kilograms. We put it on Berlin heart, supported for 14 months. The 4.6 kilogram baby has 13.1 kilogram when the patient got the heart. So it was a long pathway and the challenges several times. We need to change the VADs and other things. So over the years, in the past 10, 15 years, our way of understanding is significantly changed. um, the concepts of disparity is one of the area is keep on changing. What are those? What are those disparities? Number one is weight-based patients and the type and the size of the VAD. What is the type of the VAD? If you see 5 cardiac surgeons, they have the different preferences, and whether the VAD is a continuous flow or pulsatile flow, they have the different concepts. Number 2 is mix and match is getting wide popular. Since 2016, I'm seeing this. The concept of understanding of the pulsatile flow versus continuous flow is changing. And I will come to that point during the rest of the slides. But the thing is, the mix and match means stabilizing the patient with just Berlin, not cannula, continuous flow support for short term, like 4 to 6 weeks, changing to Berlin. Then right side is with a continuous flow, left side with a pulsatile flow. All those mismatching is going on. But what is the best way? Still, it is unclear. So what is the trend now? Still ECMO short-term support in children with heart failure. The second and third generation VADs giving hope of new possibilities for the children with end-stage heart failure. And the destination therapy and as a bridge to transplant, the continuous flow and pulsatile flow, or combination of the both, or starting with pulsatile, end up with the continuous, or continuous, then followed by the pulsatile. All those combinations gives a mixed outcome, but still, which is the best pathway we should go, that we don't know. But what the literature shows, I will show you some of the examples that shows it's kind of patient specific. What type of existing situation for the patient, what type of other organs, what they are doing. So based on that, the mix and match approach is quite popular nowadays. So the methods, what I did because if we put the literature review from 2010, because I have been mentioned a couple of times, like 15 years, the VAD is progressing in the pediatric perfusion world. So if you put like 15 years, how we got, like it's thousands of articles comes out. So I reduced the number, like between 2018 to 2024. Relevant scientific literatures regarding the science and clinical specifics of the VADs, whatever we have in the pediatric population, has been analyzed. And the flow and functionality is the one area, is the point of focus. Evaluation of the effects of flow and the function of cardiovascular and hematologic, renal, and hepatic were analyzed. So that is the reason I mentioned when we talk about the support ventricular assist device, it's not just one criteria that the protecting the heart, but it is multiple organ protection. So VAD-related complications, the need of alternative VADs were analyzed. So this article, first, the mechanical circulatory support in pediatric patients with biventricular and univentricular hearts. If I put like this, the conclusion you may not be able to go through, so that just the main points, I put it together here. Different etiologies, ages, pump type, mechanical circulatory represents a promising palliative and bridging therapy for pediatric patients. And that is the reason in the very first slide I mentioned, it is the progressive advancements is happening. Number 2, increasing experience, improved devices, and better patient selection. Mechanical circulatory support may become a valuable treatment option in patients with failing univentricular circulation, because over the several years, the univentricular biventricular combination is what type of support we should go. That was a huge question among the perfusionists as well as the surgeons. Now, the promising results that shows over the years what we learned and what the publication says, we have the promising results in the pediatric population in terms of ventricular assist devices. The other area of concern is not the concern, the area of point of focus is the flow pattern. So what these authors are suggesting, optimization of the future VADs with respect to optimal flow conditions. That is the reason very first slide I mentioned, the pulsatile versus non-pulsatile. So the optimal flow conditions, how to define the optimal, as I mentioned in the previous slide, it is not just to protect the heart, but it is based on what are the other existing conditions is present for the patient and what type of support, either one way, that is pulsatile, or pulsatile and continuous, or right and left heart support. So all those combinations gives a promising results. So how to define the short-term VADs? So again, these authors comes with the 4 findings. Number 1, thorough understandings of the available devices. Again, the thorough understandings, when we go, if you read 4 or 5 articles, different surgeons has different preferences, but patient-specific indications and contraindications should be considered. As I mentioned, heart is not the only focus, and also protecting the other organs. Technical specifics and timely decision. The timely decision is one of the key area that outcome is, we can see the progressive outcomes that are based on the timely decision. Review of the critical factors to be considered for successful outcomes. What type of critical existing condition is going on within the patient, but based on putting on a VAD for a specific VAD, what are the complications we can anticipate, that those areas we are still learning, and whatever the thorough understandings what we have, that is still, we can see a promising results. As I mentioned in one of my slides, the decision making is the huge key area for the better outcome. So these authors concludes patient-specific need and the timing of decision making for a successful outcome. So again, whether it is a center, what is the continuous flow is the good one, or the pulsatile flow is the good one, or the combination is good one. Again, the definition is not clear, but the thing is, patient-specific need, not just to focusing on the heart, but overall the multi-organ protection. In terms of multi-organ protection, the timing of decision-making for a successful outcome. So next to these authors comparing the pulsatile versus non-pulsatile flow. So here, encouraging and successful outcomes from continuous flow VADs in peds is getting wide popular after 2016, because perfusionist mindset and the surgeon's mindset, we thought pulsatile is always better than the continuous flow, but in the neonate and infant population, that is not true. Why it is not true, I will get to that point in the coming slides. So from the discussion standpoint, when we consider the Berlin Art is the one of the federal approved pulsatile device what we have. From the beginning, we had some issues with the valve portion of the pumps. That is still exist. And the complications include thrombus formation, strokes, bleeding, and infection based on the literatures and personal experience based. But the thing is, it's a good device, and the wide range of patient population we can support with this with this device. CentriMag and PDMag is a wide popular. It's working on single platform, and we can choose the pump, PDMag or CentriMag, that we can support the patients either up to 15 or 20 kilograms with the PDMag, and about 20 kilograms we can go with CentriMag to give almost 10 liters of flow. It is having a great outcomes when we support. In our experience in 2021, and newborn babies at Johns Hopkins, we supported for 180 days and patient discharged from the hospital with a PDMag centrifugal pump. I think I presented this paper at the American Academy in 2022. So again, the continuous flow VADs, patient-specific decision-making keep changing as needed. Multiple VAD interventions or flow-specific VAD support inevitable. How to keep us competent? This is the question I asked in the previous session. Frequency of implantation makes a role. You know, I always describe it as the 3 steps of learning. Number 1 is you need exposure. Number 2, you need education. Number 3, you need the experience. So these 3 things together will make us a competent perfusionist to take care of this type of low frequent and highly sensitive patients. And in addition, they are saying the continuous flow VADs, when we talk about the continuous VADs, have demonstrated improved survival and reduced complications compared with the pulsatile flow VADs, because as of now, the realistic pulsatile flow is only what we have is the Berlin Art device, the pediatric population. So this is the one of the key area when we talk about whether it's a pulsatile is good or continuous flow is good. So these are the conclusions based on the vascular pulsatility. That means the immature vessels of the infant and neonate population, the flow what you're giving as the continuous flow, that creates a non-physiological pulsatility that is better for some of the neonate infant population. In our experience, couple of neonates and infants, when we change from the Berlin to continuous flow, the renal function much improved. So these authors concludes vascular pulsatility during continuous flow VAD, This results demonstrates an application to increase the hemodynamic energy provided by the continuous flow devices being useful to the development of the improved pediatric mechanical circulatory devices. So the next one is the registries, what the pediatric VAD registries suggest. So they're going, the use of continuous flow VADs is increasing the pediatric population, short-term paracorporeal or intracorporeal use in pediatric population is widely increasing. The number of patients year after year, we are seeing so many patients coming with this type of support that is very much useful, that shows a progressive, better outcomes. When we talk about the pulsatile flow VADs, left ventricular assist device is always with the pulsatile people prefers, and the thrombosis at the outlet of the valve. And when we talk about the outlet of the valve is one of the major complications, and very frequently we are seeing this one. And multiple VAD-related issues, complications, and back to the continuous flow support is more common. VADs in pediatric, up to date from literatures, what they say, overall in the pediatric VADs, is they compare all the VADs, whatever it is available in the market or in clinical use. They are saying, they are giving a few conclusions. That means pediatric patients with end-stage heart failure, timely decision. Frequently, I'm mentioning about the timely decision. Early LVAD use and experience makes the urine. The more we do, more we can get the exposure experience, and we can get our practice, we can change our practice. This makes VAD support a standalone therapy for medically resistant heart failure ability to return patients even they can go home. So the complications, with reference to the complications, again, the thrombosis, neurological injury, infections, and bleeding, all these things are, there is no any specific reason why it is happening, but these are all the complications you can see any VAD-related literatures quite often. So there is how is the outcomes when you're putting a patient on VAD, when the patient is going for bridge to transplant, post-transplant, how these patients are doing overall. The conclusion says VAD support for 2 to 4 months before transplantation was associated with the best post-transplant survival. That is the reason the time of decision, the timing decision is very, very important, because once the heart is started, you feel whether the heart is ready to accept the VAD. At the same time, the next thought, what is very important is, because of compromised function from the heart, what are the other organs is getting failed frequently. So the timing, the timing is very, very important. In continuous flow devices support 3 weeks. The literature says over 3 weeks was associated with the greatest benefit. Again, the longer the time we support, sometimes we may face complications. But in our experience, once if you have all algorithmic conditions to manage the VAD patient, which is very good because we supported a newborn baby for almost 180 days. Most pediatric patients bridge to transplant on a VAD should be supported for some time before listing for before going for the transplant to optimize the hemodynamics. That's what these authors concludes. So recently, in the past 2 years, we are hearing about this ProTech Dio configuration. That means I couldn't find more cases to get which direction we are going. It's really a good right heart bypass support. Very, very few literatures available as of now to show promising results with ProTech. So the findings are, continuous flow VAD physiologically well tolerated over the long term. It is evident that continuous flow much helpful on renal function compared to the pulsatile flow, since we have the option with increased flow. That increased flow helps the patients with non-physiological pulsatility, as I mentioned, vascular pulsatility, as I mentioned in one of my slides. Flow-specific and patient-specific VAD support and the timely correct decision-making could eventually lead to a better outcome. Future studies examining the hemodynamics, effects on end organ function, and the efficacy of flow-specific VAD support system are needed. Limitations with reference to the limitations of VAD as of now in pediatric population, although the mechanical circulatory support field has improved significantly over the past 3 decades. Patient versus size versus selection criteria. This is one of my objectives. As I mentioned, the disparity between the surgeons and the practice guidelines. And how to maximize the biocompatibility and hemocompatibility of current systems, still it is not clear. We are in the learning phase. And complications means coagulation disorder, gastrointestinal bleeding, pump thrombosis, device-related infections, hemolysis, and cerebrovascular disorders remain the most critical challenges, but we are learning and the outcomes are very much promising in the past almost 5 years. So, where's in pediatrics? If you see SANIVAL 2024, if you go to the website and click on the SANIVAL 2024, I think the organizing committee under Richard probably, they give the theme, sea, sand, and science. That's what I put on the lower side of the, all the slides. There is no combination. Sea is something different. Sand is something different. Science is something different. I don't know why you put sea, sand, science. But what way I understood this concept, a mixed up of collection of things. If you take a handful of sand, it's a mixing of several things. If you see the water, the ocean, it's a combination of several things. Again, when you come to science, it's a combination of several things. So, where in pediatrics, it is in the revolutionary and evolutionary phase, as we discussed. The challenges, frequency of implementation, more frequent learning, exposure, all those things will make you a competent professional. But what is the take-home message? I'm not a surgeon to suggest this is better than the other one. But what we can do is, as I mentioned, as I asked the question to the panel in the previous session, what is the sea, sand, or science specifics of my presentation is everyone is not getting the same type of exposure. Everyone is not getting the same type of learning experience. Everyone is not getting the same type of experience. But the thing is, someone is getting exposure, learning, and experience. So what is very important is educate others the current environment so all the other people can learn and we can become as a competent practitioners to do the best thing what we can do to our patient population. So in summary, progressive advancements in ECMO and VATS represents complementary modalities of mechanical circulatory support that can both be used effectively in children with cardiac disease. Flow pattern, specific VAD, that is continuous flow and pulsatile flow support shows clinical relevance based on patient need and timing of correct decision. A flexible approach to the individual patient is required to optimize the mechanical circulatory support and better outcomes in this type of challenging patient population. Thank you for your presence and attention.
Isaac. Ooh, and that, wow. Okay. So Isaac, we're going to have you stay up there. In relation to the next two talks, they're going to be more of the experience of being overseas doing pediatrics. Mm-hmm. We're going to have you stand up there right now, if you don't mind, and we're going to do a little Q&A session with you. Sure. And the next two, I'll be up there with them. Mm-hmm. All right. So this is the time for Isaac to discuss this unbelievable talk that you just made. Literally, it could be 2 sessions worth of discussion. Right, I bet. And I'm going to open it up to the forum to, ask some questions and discuss this with Isaac a little bit more.
Rich.
Yeah. Hi. It's interesting that you were saying about all the complications and how we are developing. And we are learning more and more every day. And I obviously work in a center where we have a lot of these children coming in. The timing is almost understated in what you were saying. The amount of times that we will put in a VAD at the wrong point, and the outcomes are then catastrophic. Most children deteriorate in a sort of sine wave pattern as it goes generally downhill. And if you get that at the wrong peak or the trough, even, you actually find that those children won't do very well. And they were the ones that have serious complications in terms of neurological injury. Mm-hmm. We actually had with the Berlin Hearts, for example, it's an international collaboration a long time ago, which looked at whether or not we should actually be doing this at all, because the outcomes of neurological injury were so high. I think it was about 70% of the children that were getting these VADs were ending up with some, gross neurological dysfunction because of clotting issues and everything else. The question really is, how do we try and actually manage those because we can manage different types of flows. That's not easy, but it's preventing that clotting, preventing those injuries, especially when you have very few hearts coming available for transplant, and these patients can stay on VADs for years. How best to do that?
In my experience, how skillful your surgeons are, that plays a huge role. If you start a VAD program and the surgeon is just trained or just starting the VAD program, you can see the huge difference. You may lose a lot of patients. People, those who are having surgeons, those who are having a good experience, longer experience in a variety of patient population, and they were comfortable. First of all, what I noticed, they are not waiting for a wrong time for the VAD implantation. So the timing of the VAD implantation and the type, for example, traditionally, if the literature says goes with the continuous flow or ventricular pulsated flow, if you put a patient on continuous flow for the initiation purpose, it doesn't mean the continuous flow is going to be the good for the patient as long as you're supporting the patient as a bridge to transplant. As the things going on every day, that we may need to change to take care of the patient needs. That's the reason I mentioned how skillful your surgeons are, how comfortable they are in making those decisions is, in my personal experience, is having a huge impact on our outcomes. All our patients, whomever we end up with putting the patient, the need, in the past we felt like pulsatile flow is always good. Now the trend is not the same. We can mix and match also. Right side is with the continuous flow and the left side is the pulsatile flow. This type of combinations is giving a huge impact on the positive outcomes in our patient population, especially the neonate and infant population.
Hey, Isaac, nice talk. Jim Rager, Cincinnati Children's. So this is a little bit of a response to what Richard just said, and then a question for you. So there's an action network that a lot of people have probably heard of for mechanical support for children, something that they've done and had a huge impact. And I'm not going to give you a number because I don't want to misquote the percentage, but the percentage of neurological issues and deficits for kids really on any VAD, but also primarily on the Berlin heart was something like 30%. They've harmonized through this network their anticoagulation protocols and cut that drastically. Mm-hmm. And like I said, I don't have the exact number on my head, but it's something about, they've cut it by like 2/3. And what they did was they went to using bivalve versus heparin primarily, and really harmonizing the anticoagulation protocols across all those centers that use that device. What are you guys using for your anticoagulation on your long-term VADs, Berlin heart specifically, and then centrifugals?
Great. Thanks, Jim. That is the reason I said there is two different types of divisions when we talk about the VADs. Number one is science and specifications, clinical implications. The next one is anticoagulation. I didn't touch about the anticoagulation, but our practice at Johns Hopkins is bivalve. Immediately the next day we put the patient on bivalve. We are currently kind of a low volume center, so probably if I include my experience from back in Vanderbilt, a couple of weeks back I did a Berlin, so that is my 28th Berlin implantation. In the 20th Berlin, I think 26 done well, no issues at all. Only one patient had a stroke. So that is the reason I mentioned, but if we compare the same data several years back, starting from 2011, 2010, the stroke, as you mentioned, the 30-35% is coming up. So now my understanding is it differs from institution to institution. The more you are doing, the more you are learning, you have the more skilled surgeon in your centers, that those type of complications significantly coming down. Very first patient we supported for 14 months, and the patient went out after the transplant so nicely. And after I came to Johns Hopkins, I think last week what we did is like 11th case, Berlin. None of the case had any issues with the neurological complication, very smoothly. The longest time is like 7 months we supported. The shortest time is maybe 2.5 months. But the thing is, we never had any kind of VAD-related issues, and including, even as you mentioned, the anticoagulation makes a huge, as long as you are maintaining those numbers, within the therapeutic range with bivalve, you can check, because our perfusion team has two times we rounds the patient when the patient is on VAD. And also there is an exclusive dedicated VAD coordinator along with the nurse practitioners. So we are like 4 times they are checking and documenting. So we don't feel any deposits on the valve and other things. Those type of management is hugely impact on our patient outcomes. It's a evolutionary phase. We are learning more, and we are seeing a progressive outcomes in our patient population.
No real questions from the online community, but a few comments. And this speaks to what you asked Tristan earlier, that exposure to these devices for us as clinicians is the key to keeping competent and keeping up with everything and making everything work well. So just that comment.
Yes.
And if anybody wants a refresher on ECMO, we do have a hands-on ECMO session this afternoon, so you can increase your competency there.
Yes.
We don't have Berlin Heart, though. Sorry.
Sure.
Hi, Isaac. Erin from
Hi, Erin.
Children's in Washington, D.C. I have a quick question, and I don't know, some other people in the room might be able to also chime in on this, but we use Berlins and we use Centromag, and oftentimes we'll start off on a Centromag or a PediMag and then transfer to a Berlin, or we'll start off on a Berlin and then go backwards to a PediMag, depending on how the patient's lungs are doing, or if they're worried that the lungs are not going to be enough. And the thinking is we can put an oxygenator into the PediMag. You can't do that in a Berlin. Here's the problem, though, is that we put the oxygenator in, and our ECMO team, Perfusion doesn't sit ECMO, we have a whole ECMO team, does not sit on the patient because it's not ECMO, it's a VAD. And they don't have specialists for the VADs, they only have specialists for ECMO. So now we have a patient with a VAD and an oxygenator and a heater cooler, and sometimes plasmapheresis or other things with less monitoring and less pressure lines, and nobody is sitting and watching them. So my big question is, when does a VAD become ECMO? And when should we start staffing as it is an ECMO case instead of a VAD case?
Great question. So as I mentioned, one of our neonate, we supported for 180 days with PediMag. That patient gone through everything, dialysis, CRRT, and all those events it went through. So I term it as a professional, cultured workflow. So in our center, only for the troubleshooting, they will call us if something goes wrong. Otherwise, our ECMO team is quite comfortable when the patient is on VAD for transporting purpose, or if the patient requires plasmapheresis, or if the patient requires a CRRT, always a dedicated 2 ECMO specialist will be available when the patient is on the VAD. So how to make big things to happen? The key players should involve cardiac surgeons, intensivists, and the ECMO team managers and the perfusion team should involve. You know, my team is a small team, 3+1. You know, 4 perfusionists, 3 people, 24/7, and the 1 person is available when 2 CCPs are out of town. Though in that case, we have frequent cases every day. I can't sit behind the pump for 24 hours, so 24/7. So how we are educating between the team, that is the reason I used to mention exposure, experience, and educate. So that if you have this triangular formula between all the providers, we can do our best for our patient population without compromising. As you mentioned, no one is sitting and watching. Patients are coming, trusting us, you know, whatever the best we can do within our system, we can do. Any other questions?
There it is. Isaac, that was wonderful, phenomenal presentation. Aaron, I just have one comment for you and maybe get a little chuckle out of everybody. I actually had the same conversation with our ECMO program director, okay? So let's talk Centromag oxygenator, okay? They're not comfortable with doing anything with that. Am I correct on that concept with them? They just don't, right? So the Centromag is an extracorporeal device, right? Okay, and you have an oxygenator in there, correct? That's a membrane, and it's including oxygenation. So I believe that's ECMO. There you go. There it is. There it is ECMO, right?
Yeah.
Full body. Yeah. Yeah.
That's where the exposure and education starts. What you just explained now, once we are all on the same page in understanding the exposure and experience and education, we can take care of our patient population. And we know very well our job description and accountability. So thank you, everyone.